Thank you for joining me. I'd like to also thank Dr. Garg and Implant Seminars for giving me this opportunity. I'm Dr. Michael Morchat. I'm the in-house oral and maxillofacial radiologist here at Implant Concierge. I'm not trying to make this a sales pitch, but if you don't know who Implant Concierge is, we provide surgical guides. And so you have to imagine the number of radiology volumes that come through our business that they needed someone like me, an oral maxillofacial radiologist, to do the interpretations. And so I will get requests anywhere from something simple as asking about bone quality all the way to very large pathologies, pathosis. So by the end of this presentation, I hope that we'll have a better idea of identifying TMJ anatomy. Now, I'm not going to cover all of the anatomical structures because you have to understand cone beam CT is not ideal when you're looking for soft tissue. Now, we can have an idea of what's going on with the soft tissue based on the osseous changes, but cone beam CT is not good for looking at soft tissue. So I'm just going to review the osseous structures and the bony areas. Also, be able to have a systematic approach in recognizing abnormalities. Again, I'm going to touch on the basics, the ones that you're going to see the most often. I'm not going to get into abnormal tumors or anything, or neoplasms, but basically just the findings that you're going to see the most often. It's important to know temporomandibular joint because you have to imagine nowadays with cone beam CT, how many people are taking full head scans of the patients and looking for airway issues. So of course the temporomandibular joints are going to be there, and you'll be shocked. I'm going to say, there'll be interesting findings in almost 50% of the population. Also, learn a fundamental interpretation technique to improve diagnosis. And again, I'll be looking at really the main unusual findings and pathosis that you'll see in the cone beam CT. So just to make sure that we're all on the same page, I think this is very important so everybody knows what the main views are. Not everybody has a cone beam CT, not everyone uses the software that it comes with. So it's important to know what are the main three views when you're looking at a cone beam CT. So first you're going to have your axial view, which is going to be parallel to the floor. You're going to have the coronal view, which in my opinion is my favorite. This is, you're going to get the best idea of the maxillary sinuses, all the paranasal sinuses, the TMJ, and so forth. And then, of course, you're going to have the sagittal view, which is going to be your left and right. So mid-sagittal plane is going to be in the center, and you're going to be able to go left and right from there. Now, I still consider the reconstructed panoramic view the gold standard. This, you're going to be able to see pretty much everything that we're used to seeing as dentists. Don't forget, like when we were in dental school, this was one of the main views that we always had, this and periapical films. So I still think the reconstructed panoramic view gives you the best idea of what's going on in the patient. You can see the condyles, you can see the maxillary sinuses, you can see, the tooth-bearing areas and the dentition themselves. So this is definitely, in my opinion, still the gold standard. And I include this in all of my radiology reports. This is the very first image that you're going to see. So I often talk about the systematic approach. What is the best way to look at a cone beam CT? You become more and more efficient at it if you use the same system every time. And like I said, my personal favorite is the coronal view. So if you imagine, we can all do radiology reports. It's what you find as your comfort zone or your area of interest that you're going to do it or not. And as you can see here, if you become more efficient at the way that you looked at the cone beam CT, then you can complete them a lot quicker. And you gotta imagine, there's some people out there, some of you dentists, you can make $2,000 an hour with a patient in your chair. You can't make much money looking at a cone beam CT. So again, there's an example of what your comfort zone is really. Here's a beautiful example of a really nice condyle and a TMJ. As you can see here, there's good volume, and volume being the shape of it, this nice and round and bulky. There's a thin and continuous cortical outline. Here you can see in this rest position that the condyle is resting in the mandibular fossa. So it's not, where the articular eminence is, it's right nice and center. And there's a nice spacing of where the disc is. Again, we can't see soft tissue, but we can see enough knowing that there's no osseous changes here. There's no degeneration. So like I said, we're just going to touch on the most basic, important anatomical structures. And I'm sorry if this sounds really, really basic, but it's important. Again, not everybody has the same scope of practice and the same understanding, but these are going to be the main structures that you're going to see. And again, you don't see soft tissue, but you can see the osseous changes, and that's going to help you make a diagnosis. So of course, you got your condylar head. You have your condylar neck, of course, connecting the ramus to the condylar head. You have the articular eminence. So this is where the condyle is going to be gliding along with the disc. And in an open position, and you're going to see an example in a minute here, that when it's in open position, the condylar head is going to sit at the apex of that articular eminence. You have the mandibular fossa, and this is where the condyle is going to be sitting inside the mandibular fossa. And this is what's going to help it guide. And right away, here you can see that there's a nice spacing between that condylar head and the mandibular fossa. Of course, your ear canal. If you're not used to looking at these cone beam CTs, you might not know what it is when there's just a giant hole in the head. But as you can see, this patient has a little soft tissue thickening there, which is, of course, a little earwax. And then your mastoid air cells. Now, this is an area that is often missed or just skipped over. There's this thing called mastoiditis. And so basically, if there's fluid filling or soft tissue filling of the mastoids, this could be causing, severe pain in the TMJ or causing headaches. This is an area always to examine, especially when a patient's coming in complaining about TMJ pain. It might not be associated with the temporomandibular joint at all. And of course, the articular disc. This is going to be resting in between the articular eminence and the condylar head. And as you can see, this patient, real nice shape or spacing, really nice spacing here. And another thing to note is when you're examining the TMJ and looking at the anatomy, is there equal distance bilaterally? Is the condylar head touching the bone on one side and then there's, a big gap on the other side? These are all findings that really should be spent time examining. And again, we're not going to cover these things, but there's so many anatomical structures with the TMJ. You got to imagine how complicated a joint it is. You have articulation and rotation of the condyle all at the same time. And so there's a lot of muscles, articular cartilage, the capsule, and if you guys remember, the lateral pterygoid muscle is what attaches to the capsule and to the neck of the condyle. So again, here's a great example, really nice condylar head here. As you can see, the condyle sits right in the centric part of the mandibular fossa. And then again, in open position, that condyle is going to slide and rotate so that the condylar head is at the apex of that articular eminence. Here's an example of hypermobility. So if the condylar head is either in front of the articular eminence or behind, this could be caused, and again, unless you can see the patient, and I only get a snapshot of time, what is the patient doing? Is there rotation? Is there articulation of the condyle? And in this example, there was hypermobility. As you can see here, the condylar head is just anterior to the articular eminence. So now let's talk about some of the most common abnormalities or common findings that you're going to see on a patient. This one, you can see there's very minimal flattening of the condylar head, and then that little extra piece of bone right in the anterior portion, that's what's called osteophyte formation. And now this is an early stage, and you can actually see that the cortical outline is slightly thinned on the superior surface. And all these findings are going to be leading you towards, is this remodeling, or is there something more severe, some kind of pathosis or pathology? And so here's another example. This is, you hear the term quite often, oh, there's beaking of the anterior surface. It's not a term that we like to use, but that's what it looks like. It does look like a bird. But look how there's no space for that articular disc. So that the disc is either displaced anterior or posterior. In this example, most likely it's displaced posteriorly, based on where else would the disc be at this point. Another very common finding, these are what's called subchondral cysts. So note that there's a little bit of sclerosis plus little low densities along the surface. And so when you're describing a condylar, the condyle, the main description is, is the cortical outline thin and continuous? What is the appearance of the trabecular bone pattern? And so these are what's called subchondral cysts. And so what's going to happen is the bone around it will start breaking down. And that's why you have these low densities. Now, they're not real cysts, they're basically just gaps of the condylar head. But as you can see here, this patient has sclerosis, and those subchondral cysts will start degrading, and then you're going to have loss of volume or height of the condylar head. Like I wanted to show you, you go from something that's mild to now to something way more extreme. Just interruption of the cortical outline, surrounded by sclerosis, no significant osteophyte formation, but now we're leading towards something that is an active degenerative process versus something that's just remodeling. So as radiologists or as dentists, we're almost like detectives. We're not given the exact information, and as patients always lie. They have an injury, their feeling fell out, and whatever story they want to give you, and that it's never, these issues don't just happen overnight. They do take a long period of time. And so here's an example. Now, if this was a 22-year-old that came into the office and you started to see some of this flattening, you might be concerned. Now, it's not severe, but it's something early. This is something now you want to get your patient into a night guard. But in this example, being a 56-year-old, again, being a detective, now it's something that's, oh, okay, this is just long-term mild degeneration for this patient. But again, if this was a 20-year-old, something that you might want to be concerned about. Being a 56-year-old, this is most likely just long-term remodeling. Okay, so now when we're looking at pathology, this is the structure that the workflow that you really want to go through. If you remember your board exams, you're given an image of radiographic, and you had to immediately guess, oh, that's a periapical cyst or OKC. That's not really how it works in radiology. Basically, there has to be a systematic approach when you're looking at these volumes and you're looking at pathology. And so really, once you get a really good description or image analysis, this is going to lead you to a good impression. And what I'm going to show you in the next slide, what that means is if you start seeing something that's a low density, if you start seeing something that's corticated, you're going to be leaning towards something that might be a cyst. You're not just all of a sudden going to be like, oh, this is potentially dysplasia or neoplasm. You know, once you get yourself in a bucket saying, oh, it's cystic, then you have to think of all the different kind of cysts it potentially could be. And of course, with the image analysis, you know, where's the location? You know, I'm veering a little bit away from the TMJ, but this is very important. Like if there's a low density below the mandibular canal, you're going to consider something that's non-odontogenic versus something that's above the mandibular canal. What are the internal structures? Is it low density? Just like I was describing with the subchondral cyst, you know, it's more severe when there's subchondral cysts surrounded by sclerosis. You know, what is the periphery and what's the effect on the surrounding structures? And this is, you know, directly related to looking at the TMJ because, again, we can't see the soft tissue. You can have a soft tissue density, but you can't see the capsule. You can't see the ligaments, but you can see what changes are happening to the osseous structures that's going to make you now consider that there's something a little bit more severe. And so this is what I was describing to you, the impression. So now, you know, is there a normal variation of anatomy or is there abnormality? Once there's an abnormality, what is that little bucket that we can find that it might be? Is it a cyst, neoplasm, of course, you know, malignancy, bone dysplasia? But again, once you get a good description, this is going to lead you into a good impression, and that's going to get you into the correct differential diagnosis. And of course, a tumor is a tumor, but there is, you know, a lot of different types. These are all the interesting findings that you might find in the TMJ. So of course you got your developmental abnormalities, so your condylar hyperplasia or hypoplasia. Now these are just developmental. On top of this, you're still going to have additional findings. You have like what I have down a little further down, you know, the remodeling, degenerative disease, disc displacement, and of course, you know, a lot more rare, but also findings is going to be your trauma and tumors. And if you guys remember, when you have a fracture in the anterior from a fist punch or you know, a car accident, you're usually going to have a fracture in the anterior, and then you're going to have a contralateral side fracture of the condylar head. So as I've already said a few times, this is the way you describe your TMJ when you have a report or you're describing it to the patient. But what is the condylar head doing? You know, is it normal in shape and size? Is it smaller than the contralateral side? How is the cortical outline? What is the trabecular bone pattern? So a good description would be thin and continuous cortical outline, normal in shape and size, with a trabecular bone pattern that's within normal limits. What does a mandibular fossa look like? Again, if the patient's in an open position versus closed position versus at rest, you know, where is the condyle placed? Again, should be in at rest position, should be within the mandibular fossa, and when open, the condylar head should be sitting at the apex of the articular eminence. And this is going to give you a good idea of what's happening with the disc. So here's an example of some of the findings that you'll see. Notice on the right side, that condyle looks beautiful. Nice volume, thin and continuous cortical outline, versus the left side, all of a sudden, note that, you know, there's not a lot of space for that disc. And you can see that there's remodeling, there's flattening, and at this point, because we don't see a large amount of osteophyte formation, and we're also not seeing any subchondral cysts, you're going to start considering that this is old remodeling and currently does not have an active process to it. So now it's something that's, it has discontinued. So still putting the patient in a mouth guard at this point is just going to maybe relieve pain and not necessarily reverse this process. Now here's the other side of the spectrum. A lot of osteophyte formation here, a lot of sclerosis. You can see there's sclerosis of the articular eminence. There's flattening of the spacing between the mandibular fossa and the articular eminence. And then even more extreme, because now you're looking at a active degenerative process here. Subchondral cysts, not really a lot of sclerosis, extreme flattening of both the mandibular fossa, articular eminence, and the condylar head, all of them. And as you can see, there's a lot of sclerotic bone. So this is potentially an active degenerative process. All right, quiz time. So what do some people think that this might be? It's not going to be your cemento-blastoma. It's not going to be osteoma. So here, again, you have to be a detective and kind of think about what it might be. Do we know exactly what it is? No, but this is where you want to get a differential diagnosis. So chondromatosis and the synovial fluid, absolutely possible. Detached osteophyte. Here, looking at the way that the bone is quite sclerotic, noting that there's some osteophyte formation. There's also subchondral cysts. Now we're looking at a degenerative process. So most likely this is detached osteophytes, but a potential differential would be your synovial chondromatosis. Okay, what do people think this might be? It's a little bit of a trick question because I got another slide that's going to help you make your differential diagnosis or diagnosis altogether. But notice that the cortical outline, I keep on describing, thin and continuous cortical outline. Here we don't really see the cortical outline. We don't see any subchondral cysts. We don't see some osteophyte formation, but that cortical outline doesn't even appear. So now this is the same patient. Does your opinion change of what you think it might be? And again, you have to be a detective because we only have a snapshot in time of what this might look like. Here, this is a kid. So it actually, if we go back now, looking at this is a developmental stage. As the patient's getting older, the TMJ is going to continue to grow or change up until the patient's in their 20s. And that's why if TMJ was the hugest issue, 10, 15 years ago, there was a lot of research done in it. And they really found that, the most common patient that is going to have TMD or degenerative processes with their condyles, it's going to be a female and someone that's going to be in their mid-20s. It's the stereotypical 26-year-old female is the patient that's going to have the most pain. But what happens is if the patient's that young, it's a process that's just going to end on its own. If you have a patient that's in their 50s and they have the same degeneration, now this is something that's active and will become a bigger issue in the future versus that 26-year-old female. She's going to have pain, take Tylenol, and the process will end on its own, basically. Again, There's no single perfect answer. Again, being detectives, we can look at this. These are different interesting findings. Is it idiopathic osteosclerosis? No, there's no sclerosis. It's low density. Okay. Now we also see the other images, the other subchondral cysts. So what is this large one? Most likely it is a subchondral cyst, but a good differential still potentially could be that simple bone cyst or traumatic bone cyst. If it was standalone and that was the only finding, most likely it would be your simple bone cyst, and then you would not consider the subchondral cyst if there's no other osseous changes suggesting that there's a degenerative process. So just like the other joints that you have in your oral maxillofacial region, you have to also include your cervical vertebrae, because as you can see here, it doesn't work the exact same as your condyle, but the osseous changes are going to be very similar. In this case, with your cervical vertebrae, you're still going to have those subchondral cysts. You're still going to have the osteophyte formation, but you also potentially have calcification of the ligaments. Now, as you can see here, where's the joint space between the dense process and the anterior arch? It's non-existent. So this is a degenerative process at this point. Biggest issue when you have a patient like this is those osseous changes are basically, they're just going to occur. Most often they're going to be self-limiting. And here, this is a coronal view. Of course, the more times you look at a cone beam CT, you become more comfortable looking at it. I know it's very difficult to give you basically just two snapshots and you know what you're looking at. But that's the articular facets or faucets of your cervical vertebrae, not the body, not where the disc is, but the articular surfaces, both on the left and right side of the bodies of the cervical vertebrae. But the exact same findings that you're going to see in the TMJ, basically transferable to when you're looking at the condyles. So the main findings when you're looking at the TMJ, when you're looking at the condyles, again, it's important for me to repeat myself because it is the way that you look at it and you describe it. Most of the time, you're going to be able to get a good description by using, basically a template. So it's the condylar heads are normal in shape and size. There's a thin and continuous cortical outline. That's very, very key because if there's interruptions or irregularities, that you have something abnormal. It's no longer a variation of normal. Now it's something that potentially is pathosis, and that being remodeling. That would be your degenerative joint disease. And of course, there's no perfect solution for describing DJD, but basically, it's qualitative to basically decide, is it something that's mild, moderate, or severe? But in most cases, it's a income source for the dental office. But the easiest solution is putting the patient in a night guard or appliance to relieve the pressure or the changes that's occurring to the condylar heads. All right, so I went pretty fast through that presentation, so I just added a few extra slides here. Just really interesting finds. This has nothing to do with TMJ, but really, this is very, very common. You'd be surprised. It'd be like an endodontist finding, a third canal, because you have to imagine he's getting a lot of referrals, and it's the same thing with what I'm finding. I get a lot of referrals that there is already an issue, and so what is it? Saving the patient potentially less time in the chair, not having to go to oral maxillofacial surgeon, and really getting a good idea of what the next steps are when you have a finding like this. So this is one's really, really interesting. This is your OKC, for odontogenic keratocyst, but these I just found very recent. And often incidental findings. This one most likely OKC. We can eliminate certain pathologies. It's not going to be your ameloblastoma. There's thinning of the cortical outline, but again, really, really cool finding. And this was incidental finding. Patient came in, unusual numbing sensation on her right side, and it ended up this. I should get the biopsy or find out what the end result was. It's the doctor that I'm familiar with, but this one, we know, again, being a detective, look at how the bone's just being destroyed, being eaten away. Again, we don't see the soft tissue, but we are given enough information that we can get to a good differential diagnosis. And the big giveaway for this one is, as you can see, it's associated with the greater palatine canal. And so anything that's associated with usually nerves or blood supply, you're most likely going to get the lead towards being a malignancy. Okay, so that's everything. I really hope that was informative.